Assalamu alaikum everyone. My name is Zuriyat Fatima and today I'm going to tell you about a well-known NSAID that is Indomethacin. So in these slides we're going to discuss about what is the introduction of the drug, what is the history of Indomethacin, what are its known prescriptional uses, the pharmacognostic aspects or source of Indomethacin, chemistry of Indomethacin, mechanism of action of Indomethacin, pharmacokinetics and pharmacodynamics of the drug, dose of the drug, and lastly we'll discuss about the toxicity of indomethacin. So, before getting deep into the topic, the first thing that comes in our mind, what is indomethacin? So, indomethacin, also known as indomethacin, is a non-steroidal anti-inflammatory drug with anti-inflammatory, analgesic, and antipyretic properties. Common brand names are Indocin and Tivorbex, and in Pakistan the common brand of indomethacin is Methacil. So, what is the history of indomethacin? So, it was discovered by researchers at Merck and Co. by Dr. Carl F. Huffman in early 1960. They were working on developing new drugs with anti-inflammatory properties. Indomethacin was synthesized as a derivative of indole, a heterocyclic compound. It was first discovered in 1963 and was approved to use in USA by FDA in 1965. Non-prescriptional use of indomethacin. Indomethacin appears to effectively release primary dysmenorrhea, which are menstrual cramps, and doesn't appear to be associated with high incidence of side effects. It allows many dysmenorrheic women to carry out their normal activities and work during menstrual period. What are the pharmacognostic aspects and source of indomethacin? So, indomethacin is derived from indole, which is a naturally occurring compound found in plants. The drug is synthesized from indole acetic acid, which is produced by certain bacteria and fungi. Chemistry of indomethacin. So, indomethacin is a white to yellow crystalline powder soluble in organic solvent, but practically it is insoluble in water. It is a weak acid with pKa 4.5. The chemical name of indomethacin is p-chlorobenzoyl 25-methoxy 2-methylindole 3-acetic acid. As you can see in the structure, there is an indole ring. Now we will discuss the mechanism of action of indomethacin. So in the flowchart you can see basically what happens is at the site of injury, tissue damage happens, obviously cell damage occurs. The cell membrane, which is composed of lipid bilayer and contains phospholipid, on damage they scatter. Phospholipase enzyme basically acts on it and converts them into arachidonic acid. The arachidonic acid along with cyclooxygenase enzyme releases prostaglandin PGG2, which is then converted into prostaglandin H2. The prostaglandin H2 is converted into a number of things that includes prostacyclin, PGI2, thromboxane A2, which causes vasoconstriction, promotes platelet aggregation. Prostacyclin causes vasodilation, inhibits platelet aggregation. Also, it gets converted into PGD2 and PGE2, which leads to vasodilation and increased vascular permeability. Now, here is a video in which you can see at the site of injury, inflammation occurs. Inside the blood vessels, there are actually enzymes, mediators, white blood cells. COX enzyme is also present, and during injury, when arachidonic acids activates the COX enzyme, and thus prostaglandins are released, which leads to inflammation. Now, when we give an indomethacin or any other NSAID, it actually inhibits COX enzyme, thus reduced prostaglandin production, and obviously which leads to anti-inflammatory effect. Next, we're going to talk about the routes of administration of indomethacin. So, indomethacin is available for oral administration as immediate release in 25 mg and 50 mg capsules. Extended release capsule formation in 75 mg. An oral suspension formulation 25 mg per 5 ml is also available. Indomethacin administration can also be done via an injection through the intravenous route, 1 mg base per vial. It is also available as rectal suppository in 50 mg. Talking about the pharmacokinetics of indomethacin, so we all know that pharmacokinetics actually means that what body does with the drug. So the first step is absorption. Indomethacin is well absorbed and attains peak plasma concentration at 2 hours. As I've told you before, that it can be either given orally or through parenteral route, which includes intravenous route and rectal route. Through these routes, indomethacin actually bypass GIT and thus shows rapid onset of action. Next step is distribution. So indomethacin is highly lipophilic. The high lipid solubility allows indomethacin to cross the blood-brain barrier easily. It is highly bound to plasma protein, especially albumin. Indomethacin also achieves high concentration in synovial fluid. So basically, as I told you, that indomethacin is highly lipophilic, while synovial membrane also has high lipophilicity and contains in more proportion of lipids, due to which allows indomethacin to readily penetrate the synovial membrane and accumulates in synovial fluid. Also, indomethacin is highly bound to protein in blood plasma, but for synovial membrane, the concentration of plasma protein is very low. Thus, high fraction of indomethacin that is unbound to protein, thus it shows great pharmacological action there. Third step is metabolism. So indomethacin undergoes enterohepatic circulation, which is basically that from bile it is reabsorbed by intestine and thus enters the circulation. Indomethacin is metabolized via demethylation, removal of methyl group, or through deacylation, means removal of acyl group. It produces following metabolites, which includes 5-hydroxy-indomethacin, indomethacin acyl glucuronide, and many more. Last step is excretion. So approximately 60% of the administered indomethacin is excreted in urine by renal tubular secretion. The remainder is excreted in feces after biliary secretion. Next comes the pharmacodynamics of indomethacin, which is basically what drug does to the body. So as I've told you before, that arachidonic acid gets converted into lipoxygenase and cyclooxygenase enzyme, which is basically divided into two categories, COX-1 and COX-2. So indomethacin is a non-selective COX inhibitor, which means that it also inhibits COX-1 and COX-2. So when indomethacin inhibits both of these enzymes, it actually results in reduced production of prostaglandin, which leads to anti-inflammatory effects. As prostaglandins are mediators of inflammation such as redness, swelling, and pain, so obviously reduced production of prostaglandin leads to anti-inflammatory effects. Similarly, it produces analgesic effects as prostaglandin sensitizes pain, so again its reduction actually reduces pain. Antipyretic effects, which is not that much common, but still, as prostaglandin plays a role in regulation of body temperature, and their elevated levels can lead to fever. So when we reduce the production of prostaglandin, it leads to antipyretic effects. Other effects include inhibition of leukocyte migration. So basically, prostaglandin E2 is an important mediator in leukocyte migration, and leukocyte cells actually initiate the inflammatory response. So when prostaglandin's production is inhibited, it also leads in inhibition of leukocyte migration. Next is reduction of collagenase activity. So collagenase actually is an enzyme that breaks collagen. Collagen, which is a structural protein in connective tissue, tendons, cartilage, and skin. Excessive collagenase results in tissue destruction and degradation that is often seen in rheumatoid arthritis. So indomethacin basically reduces collagenase activity. It actually inhibits the collagenase enzyme. Next comes the dose of indomethacin. So in acute pain, 20 mg 3 times a day or 40 mg 2 to 3 times a day is given orally. In case of rheumatoid arthritis, which is we know that it is an autoimmune disorder, immune system basically attacks healthy cell by mistake and cause inflammation, which is actually painful swelling. It usually affects many joints at a time. Ankylosing spondylitis is basically inflammation in joints and ligaments of spine. As we know that ligaments in spine help in moving and bending, so inflammation in them causes actually stiffness. Osteoarthritis is inflammation of joints. When cartilage that cushions your joints get inflamed and gradually starts deteriorating, this leads to osteoarthritis. So the dose for them is 25 milligram 2 to 3 times a day orally or via rectal administration as an immediate release formulation. Or alternatively, 75 milligram extended release capsules can be administered. Next disease is bursitis. So bursitis is basically inflammation of bursae or bursae. Is the small bursae are basically small fluid-filled pads that act as cushion between bones and tendons. The dose in case of bursitis is 75 to 150 milligram immediate release formulation orally or rectally in 3 to 4 divided doses. Alternatively, 75 to 150 milligram extended release formulation can be administered orally. Next comes the gouty arthritis. So gouty arthritis is also inflammation of joints. It usually affects one joint at a time. Dose for gouty arthritis is 50 milligram 3 times a day orally or rectally as an immediate release formulation within 1 to 2 days of flare onset. Next disease is patent ductus arteriosus. So it is a heart defect that occurs soon after birth. The normal connection between aorta and pulmonary artery doesn't close as it should, which causes too much blood to flow into the baby's lung. In the womb, ductus arteriosus allows blood to bypass baby's lungs and go straight to the body. Mother supplies the baby with oxygenated blood, so blood doesn't need to go to the lung first. Normally, the ductus arteriosus should close on its own within few days after birth. When opening doesn't close, the connection is considered as patent or open ductus arteriosus, and it requires closure. Dose for patent ductus arteriosus is the initial dose of indomethacin is intravenously 0.2 milligram per kg per dose. No additional dose are required if the ductus arteriosus closes or significantly decreases within 48 hours. If it reopens, a second by third dose may be required at 12 to 24 hours interval. If the infant's age at the time of first dose is less than 48 hours, administer 0.1 milligram per kg through intravenous route. If the age at the time of first dose is 2 to 7 days, administer 0.2 milligram per kg IV. If the age at the time of first dose is greater than 7 days, administer 0.25 milligram per kg IV. If the neonate is non-responsive to indomethacin, surgery may be necessary to close the ductus arteriosus. Next comes the side effects of indomethacin. So indomethacin may cause side effects like headache and dizziness. So these side effects can occur due to the effects of indomethacin on blood flow and neurotransmitter regulation. Indomethacin may constrict blood vessels in the brain, leading to reduced blood flow and subsequent headaches. It can also affect the production of certain neurotransmitter involved in pain and blood vessel dilation, which contributes to headache and dizziness. Then comes vomiting, diarrhea, constipation, ringing in the ears. So, indomethacin can affect the muscles in GIT, potentially leading to reduced motility or movement of intestine. Slower movement through the digestive system can result in constipation. Increase in absorption of water from intestine also leads to drier stools. While for diarrhea and vomiting, so basically indomethacin can irritate the lining of stomach and intestine, leading to side effects like abdominal pain, nausea, vomiting, and diarrhea. So what are the adverse effects of indomethacin? So indomethacin can cause hypersensitivity reaction, which are basically allergic reaction, which includes anaphylaxis, urticaria, angioedema, which is the swelling of deeper layers of skin like lips and eyes. Peptic ulcer. So as I've told you before that indomethacin irritates the lining of stomach and intestine. So it can also increases the risk of GIT ulcers and bleeding. This occurs because indomethacin inhibits the production of prostaglandin, which plays a role in protecting the GIT mucosa and maintains the integrity of stomach lining. It also affects on liver enzyme and can cause jaundice. and leads to liver toxicity. It has also effects on cardiopulmonary system, causes acute respiratory distress and leads to congestive heart failure. Respiratory difficulties are also one of the adverse effects of indomethacin and can lead to fatigue. Next is the toxicity and antidote of indomethacin. So, indomethacin toxicity is actually rare. Only a few cases are reported in the literature. Cases in the literature have demonstrated headache, tinnitus, dizziness, lethargy, which is weakness, drowsiness, confusion, disorientation, restlessness, acute kidney injury, secondary to indomethacin toxicity. A mild overdose of this medicine doesn't usually cause serious problem. There may be stomach pain and vomiting, possibly with blood. However, large amount of internal bleeding is possible and a blood transfusion may be needed. Endoscopy may be needed to stop the internal bleeding. There is no specific antidote to indomethacin toxicity. Next comes the lethal toxicity of indomethacin. So, lethal toxicity or the lethal dose of a substance refers to the dose at which it is lethal to 50% of the test subjects. The LD50 of indomethacin can vary depending on the species of the test subject, such as rats or mice. Also, on the routes of administration, that may be oral or intravenous. Acute oral LD50 is 2.42 mg per kg in rats and 13 mg per kg in mice. The oral LD50 of indomethacin in mice and rats based on 14-day motility response was 50 and 12 mg per kg respectively. That's all from my side. Hope you have gotten a better understanding of indomethacin. Thank you.